Good afternoon. I'm John with the Illinois chapter of the AAP, and I thank you for joining us on today's webinar for the 2017 ACIP updates. This webinar is sponsored by the Illinois and the Chicago Department of Public Health. Today we're joined by Dr. Scott Goldstein from the Northwestern Children's Practice in Chicago. Before we begin, I'd like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. If you have any questions for our speaker during the presentation, please use the text box on the right-hand side of your screen to ask questions, and we will get to them at the end of the presentation. The course directors, planners, faculty, and reviewers of this activity have no relevant financial relationships to disclose. Evaluations will be sent post-webinar by ICAAP with a link to the survey to be completed. You'll have 2 weeks to complete the survey. The survey will be closed after April 18th, so please make sure you complete that evaluation before then. Once the survey is completed, you will receive your certificate via email from ICAAP within 2 weeks of completion. Now I would like to introduce our speaker, Dr. Scott Goldstein. Dr. Goldstein graduated from Northwestern University and the University of Illinois Medical School. He is a board-certified physician and completed his pediatric training at Hasbro Children's Hospital in Providence, Rhode Island. He is also an instructor of clinical pediatrics at the Northwestern University School of Medicine. Please join me in welcoming Dr. Scott Goldstein.
Thank you. So we'll jump right in. We're going to talk about childhood and adolescent immunization. Our objectives today are to give the updates from the 2017 Advisory Committee on Immunization Practice vaccine and catch-up schedule. Talk about the best practices when administering vaccines to children and adolescents, to demonstrate the correct schedule recommendations for the ACIP scheduled vaccines, and to interpret correct storage and handling of vaccines being administered. I have nothing to disclose for this. So we're going to talk about some of the childhood and adolescent vaccines. It used to be in this talk, we would talk about all of the vaccines that are given between birth and adolescence, but that's a little too hard to fit into an hour. So this time, it hopefully will be a little bit easier to listen to. We're just going to talk about the vaccines where the recommendations where there have been changes to the recommendations for 2017. There are many serious vaccine-preventable diseases still circulating in the United States and globally that can have serious or fatal consequences for children and adolescents. Ensuring that all kids receive the complete series of each recommended vaccine is important for a couple of reasons. First, as healthcare professionals, it's our job to prevent illness in patients whenever possible. Vaccination has the benefit of not only protecting the person who receives the vaccine, but also protecting people who may not be able to get the vaccine themselves, like those who are too young or too old to be vaccinated, or those whose immune systems can't handle being vaccinated. These vulnerable groups rely on a well-vaccinated population to stay healthy. There are also less tangible benefits to childhood vaccination. Some of these diseases are acute, but others can cause chronic disease, and all of them can lead to long-term health complications. The burden of illness from vaccine-preventable disease on the healthcare system is huge. Keeping people healthy can save significant amounts of time and money, and there's also an emotional savings to keeping people healthy. When anyone, especially a child, gets sick, they're not the only one affected. Family and friends may have to help this sick person with doctor visits, treatment plans, or daily activities they can't manage alone. And there can be an emotional toll on family and caregivers as well, particularly if someone they care about contracts a serious or fatal illness. What we see here is the complete recommended immunization schedule for children and adolescents up to age 18, which is put together by the Advisory Committee on Immunization Practices at the Center for Disease Control. The orange bars represent the optimal timing of administration for each vaccine, but if a child falls behind the schedule or starts late, there are also recommended catch-up periods indicated in green. The purple bars on this chart indicate the recommended age range for certain high-risk groups, while the newly added blue bars represent the age range for non-high-risk groups that can receive the vaccine, subject to individual clinical decision-making. We'll be talking about many of these vaccines and the timing recommendations in greater detail in this module. This is the catch-up immunization schedule for any children who may have started immunizations later than recommended or who have not completed a series. This table shows the minimum amount of time that's necessary to wait between each dose in a series of immunizations. What's new in 2017? There are several changes to the ACIP recommended schedule since last year. As seen already, there are minor layout changes. There's a new 16-year age column that's added to highlight the need for a meningococcal vaccine booster dose at age 16. And the addition of the blue bar serves to highlight this recommendation for the meningococcal B vaccine, and also indicates that HPV vaccine can be given to children aged 9 to 10, even in the absence of high-risk conditions. There are also new or revised recommendations for influenza, HPV, hepatitis B, Haemophilus influenza type B, pneumococcal vaccine, the meningococcal vaccine, the diphtheria and tetanus toxoids, and H. cellular pertussis vaccine. We're going to talk about each of those as we go through the vaccine types in this presentation. Finally, there's a new informational graphic titled Figure 3. This resource aims to help clarify which vaccines might be indicated for children and adolescents age 18 or younger based on medical indication. As we move through this presentation, we'll talk about the new recommendations that will be pointed out in bold red font. As mentioned on the last slide, this is the Figure 3. It shows vaccines that might be indicated for children and adolescents age 18 or younger based on medical indication. The CDC felt it was important to create this figure as a resource for healthcare providers in order to demonstrate that most children with medical conditions can and should be vaccinated according to the routine schedule. Also to indicate when a medical condition is a precaution or contraindication to vaccination, and to indicate when additional doses of vaccine may be necessary because a child's medical condition requires it. Providers should consult the relevant footnotes for additional information. Before we move on, I'm just going to briefly touch on this concept of cocooning. Babies younger than 6 months old are vulnerable to many vaccine-preventable diseases because they're too young to receive all their vaccines. They also have higher rates of infection and more serious outcomes for most of these diseases. Cocooning refers to a way of protecting babies. Older children and adults are the main way that babies get infected. Whooping cough and influenza can be particularly dangerous and harmful to babies under 6 months. All people who may come into contact with the baby, including grandparents, siblings, and caregivers, should be fully vaccinated. This creates a cocoon of protection to help keep babies safe. Now we're going to go through some of these vaccines in more detail. First, we're going to start with hepatitis B. So there are 3 different types of hepatitis B infection. Acute infection is a new hepatitis B infection, and this may or may not cause any symptoms. An acute infection can also become a chronic long-term infection. Young children are at the highest risk for developing chronic infection, with about 90% of infants and up to 50% of children aged 1 to 5 becoming chronically infected after an acute infection. The third type is perinatal infection, which is when an infected mother passes the infection to a newborn baby. Without vaccination, approximately 40% of babies who are born to hepatitis B infected mothers will develop chronic hepatitis B infection. Hepatitis B is transmitted through contact with infected blood or body fluids when the skin barrier is breached. It's important to note that hepatitis B cannot be spread through food, water, sharing utensils, breastfeeding, hugging, kissing, hand-holding, coughing, or sneezing. When they're present, the symptoms of hepatitis B infection include fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, dark urine, joint pain, and jaundice. But most children under 5 won't have any symptoms of acute infection, and only 30 to 50% age 5 and older will have any symptoms. This means that infection can be even harder to catch in young children. About 1% of people with acute hepatitis B infection will die, but this is usually occurs in patients over 60 and not in children. The symptoms of chronic infection can range from no symptoms at all to severe liver disease like cirrhosis and liver cancer. Of children who develop chronic hepatitis B, 25% will die prematurely. There are 2 single-agent vaccines that protect against hepatitis B called Recombavax and Energex. And there are 2 combination vaccines that protect against hepatitis B and other diseases. Those are Twinrix that also protects against hepatitis A, but that's only used for patients over age 18. And then there's Pediarix, which protects against diphtheria, tetanus, pertussis, polio, and hepatitis B. There used to be a vaccine called Comvax that protected against Haemophilus influenza type B and hepatitis B, but that is no longer available. Any of these vaccines can be used to complete the hepatitis B series, so you shouldn't delay or stop the series if it's not possible to use the same brand for the whole time. All of these are given intramuscularly, and all should be stored refrigerated between 36 and 46 degrees Fahrenheit. The only contraindication to receiving the hepatitis B vaccine is a severe allergic reaction to a previous vaccine dose or one of the vaccine components. The CDC says to use caution when giving the vaccine if a patient has a moderate to severe acute illness with or without fever, or in babies weighing less than 4 pounds. It's important that the child's first dose of hepatitis B vaccine be at birth before they're even discharged from the hospital if possible. This year, the ACIP explicitly recommends giving the first dose within 24 hours of birth for medically stable babies weighing at least 2,000 grams. This is strongly recommended even if the mother is not infected with hepatitis B. Giving the first dose at this point has been shown to increase the likelihood of a child completing the vaccine series. Preterm infants weighing less than 2,000 grams should receive the first dose at hospital discharge or no later than 1 month after birth. If the mother is known to have a hepatitis B infection or if the status is unknown, these infants should still get the hepatitis B vaccine in addition to hepatitis B immunoglobulin within 12 hours of birth, as outlined on the table on this slide. Hepatitis B is given as a 3-dose series, usually at birth, then a second dose at 1 or 2 months. Has to be 4 weeks between the first and second dose. And the third dose is given between 6 and 18 months with a minimum of 16 weeks between the first dose and the third dose and 8 weeks between the second and third dose. Only the monovalent vaccines, the Recombavax and Energex, are given at birth. The combination vaccine Pediarix can only be given after 6 weeks of age, and Twinrix, as I said, is only for adults over age 18. Pediarix is not given to children over age 7. If a child does not follow the recommended schedule, they can still complete the immunization on the catch-up schedule, where they still get 3 doses that are outlined on the slide here. If there's an interruption in the vaccine schedule, the series does not need to be restarted. You just administer the next dose as soon as possible and follow the recommended timing minimum. There's also an adult Recombavax hepatitis B vaccine that can be given as a 2-dose series to children aged 11 to 15 with a minimum of 4 months between those doses. Now we're going to talk about diphtheria, tetanus, and pertussis. There are 2 different types of vaccines we'll explore for this. The difference between the vaccines is that one is for children under age 7 and the other is for children over age 7. Children under age 7 receive the full-strength dose of diphtheria, tetanus, and pertussis, hence the capital DTMP. Adolescents and adults receive the reduced strength doses of diphtheria and pertussis, hence the lowercase d and p. The A in the vaccine name refers to acellular pertussis, meaning that the pertussis vaccine component contains only part of the pertussis organism. So the DTP vaccine is commonly referred to as DTaP. That's recommended for under age 7. And just a little bit about what some of these infections are. Diphtheria is a bacterial infection caused by Corynebacterium diphtheriae. These bacteria travel to the respiratory system where they produce a harmful toxin. Diphtheria is not common in the United States because of the vaccine, but it still does present an important global health issue. It spreads through respiratory droplets from coughs and sneezes, or through contacting a skin lesion of an infected person. The bacteria can also be spread by contaminated objects like toys. Complications from diphtheria are very serious, and mortality rates from this disease are very high, with up to 10% of patients dying even with treatment. In children under age 5, fatality rates are even higher, up to 20%. Diphtheria used to be a leading cause of illness and death in children in the United States, but since the introduction of the vaccine in the 1920s, the rates have plummeted. Between 2004 and 2008, there were no cases of diphtheria reported in the United States, although, as I said, it's still an important health issue globally. Tetanus is a bacterial infection caused by Clostridium tetani. The toxin produced by these bacteria can get into a person's central nervous system, to their spine, the brain, and into their sympathetic nervous system as well. The bacteria that cause tetanus are present in the environment, including soil, dust, and manure, and they most commonly enter a person's body through broken skin, like through crush injuries or puncture wounds. The most common initial symptom of tetanus is spasms of the muscles in the jaw, called lockjaw. Other symptoms include muscle spasms in other parts of the body, headache, difficulty swallowing, seizures. Complications can be very serious, and up to 20% of patients with generalized tetanus die even with treatment. It's a medical emergency that requires immediate hospitalization. Cases of tetanus in the United States have decreased by about 95% since reporting began in 1947, mainly due to immunization. Now cases are most commonly found in adults who have not received the tetanus vaccine in childhood or who are not current on their boosters. The main reason why we give this vaccine is for pertussis, which is also known as whooping cough, an infection caused by the bacteria Bordetella pertussis. This bacteria produces toxins that in children is worse in children less than 1 year old. Children aged 7 to 10 have the second highest rates of infection. There are 3 stages to the illness to pertussis illness, beginning with something called the catarrhal stage, which usually lasts 7 to 10 days. These are just general viral symptoms: fever, stuffy nose, sore throat, cough. This is followed by something called the paroxysmal stage, which is severe rapid fits of coughing, followed by the characteristic whoop noise that accompanies inhalation of air. Although this whoop noise isn't always present in adolescents, it still needs to be kept in mind in the differential diagnosis of anybody with a chronic cough. This paroxysmal stage lasts anywhere from 1 to 6 weeks. The final stage is the convalescent or recovery stage, where the cough lessens in frequency but can continue for several months longer. Infants with pertussis may not have a cough, they may only have apnea, but it's very important to diagnose pertussis in this population because they're most at risk for severe or fatal complications. About half of infants under age 1 will need to be hospitalized. Pertussis is highly contagious and usually spreads through respiratory droplets from coughing or sneezing. Half of babies, as I said, under a year old who get it will be hospitalized, and 1% of those will die. Treatment is with antibiotic, and if given early, will lessen symptoms and decrease the amount of time that a person can spread the disease to others. The DTaP vaccine is a 5-dose series for children under age 7. There are several brands of DTaP. All are combinations against diphtheria, tetanus, and pertussis, but some protect against other diseases as well. Pentacell also protects against Haemophilus influenza type B and polio. Pediarix, we talked about earlier, protects against hepatitis B and DTaP. There are 2 other ones called Kinrix and Quadracell that can be used as the 5th dose in the series, and 4 to 6-year-olds that protect against DTaP and polio, as well as that's Kinrix and Quadracell. The recommended vaccine schedule is to give the doses at 2 months, 4 months, 6 months, then between 15 and 18 months, and then between 4 and 6 years. However, the first dose can be given as early as 6 weeks, and the 4th dose can be given as early as 12 months, as long as there have been 6 months between the 3rd and 4th dose. If a child falls behind on the schedule, they can still finish the series. There has to be a minimum of 4 weeks between dose 1 and 2 and 2 and 3, and a minimum of 6 months between dose 3 and 4 and 4 and 5. If a child receives their 4th dose at 4 years or older, they do not need to get a 5th dose. There is new guidance this year from the ACIP if a 4th dose is inadvertently given too early. If the 4th dose was given at least 4 months after the 3rd dose and the child is over 12 months, you don't need to repeat the 4th dose. If a child does not complete the vaccine series by age 7, they need to complete it with the Tdap vaccine, which we're going to talk about next. All the Tdap vaccines are given intramuscularly and stored at 36 to 46 degrees and should not be frozen. The contraindication and precaution list is linked to on this slide. The Tdap and Td vaccines are a continuation of protection for adolescents and adults over age 7. They're given in addition to the DTaP series we just talked about and can be used to help catch up older children who aren't fully immunized. Tdap vaccines are only for use in children aged 10 and older and have the trade names Adacel and Boostrix. Td vaccines are used in children aged 7 and older, and there are 3 types available: Tenavac, DT generic, and TD generic. It is recommended that children get a Tdap booster between 11 and 18 years old, although it's preferred that this be done at the 11-year visit. TD booster shots are given to all adults every 10 years or as needed in case of exposure. If an adolescent does not receive the Tdap vaccine between 11 and 18, they should get it as soon as possible at any age, and this can replace one of the 10-year TD boosters. If a child did not complete the DTaP series by age 7, they're not fully protected and should complete the series according to this catch-up schedule. The catch-up doses need to be tailored to each individual based on their vaccine history, but it's preferred that the first catch-up dose be Tdap. The remaining doses can be TD. Then they will receive the TD booster every 10 years. If a dose of DTaP is inadvertently given during the catch-up schedule when the child is 7 to 10 years, this can still be counted as a catch-up dose. This can also replace the regularly scheduled adolescent Tdap dose, or the adolescent Tdap dose can still be given as usual. If a dose of DTaP is inadvertently given at 11 to 18 years, this still counts as the adolescent Tdap dose. The Immunization Action Coalition makes a table that summarizes the DTaP, Tdap, and TB vaccine timing recommendations and is an excellent resource. Immunization.org link that should be on the slide. All Tdap and TD vaccines are given intramuscularly and refrigerated, and the precautions are linked to here as well. Tdap vaccine is particularly important for pregnant women. They should be vaccinated at each pregnancy, preferably between 27 and 36 weeks. For 2017, the ACIP recommends vaccinating as early as possible in that 27 to 36 week window because this maximizes passive antibody transfer to the infant. If a woman is unvaccinated at the time of birth or if vaccination status is unknown, Tdap should be given immediately postpartum before the mom goes home. The Tdap vaccine for pregnant women has two main benefits. One is the maternal antibodies transferring to the baby and offering some protection before the baby can get the first dose of Tdap, and also prevents the mother from passing disease to the newborn baby. As we discussed, pertussis in particular is highly contagious, and infants are at the highest risk for severe or fatal complications. For this reason, it's also recommended that any family members or caregivers are also up to date on their DTaP or Tdap vaccine. The next vaccine that has some newer recommendations this year is Haemophilus influenza type B. So there are 6 identifiable types of Haemophilus influenza, types A through F, and some other non-identifiable types. But there's only a vaccine that protects against type B. Haemophilus influenza type B bacteria typically remain in people's nose or throat and don't cause any symptoms, but they can travel to other parts of the body and cause more serious infections. The most common types of invasive infection are pneumonia, bacteremia, and meningitis. Since the introduction of the vaccine in 1990, Haemophilus influenza type B has decreased dramatically. However, children under age 5 still experience the highest rates of infection in the United States. The children at highest risk of infection are infants who are too young to have completed the immunization series. Haemophilus influenza type B is transmitted directly from person to person, and also it's spread through direct contact as well, through respiratory droplets, from coughing and sneezing. Symptoms can range from mild fever, cough, nausea, to some of these more severe manifestations like pneumonia and meningitis. Prior to the introduction of the vaccine, 20,000 children under age 5 contracted invasive infections every year, and 1,000 of those would die. There are significantly less infections now, but most invasive Haemophilus influenza B infections still require hospitalization. Up to 20% of kids with infection with meningitis will have permanent neurologic sequelae, including deafness and seizures. And about 5% of these kids will die of it. The vaccine was introduced in 1990, and the incidence of severe infection has decreased by 99% since then. There are several types of vaccine available. Some protect only against Haemophilus influenza B, and there's also combination vaccines. The ACT-HIB, PEDVAX-HIB, and Hiberix protect only against HIB, whereas in previous years, the ACIP had recommended using Hiberix only for a booster dose. It can now be used in the primary series. Menhibrix and Penticell are the combination vaccines. And as I said earlier, Comvax, an older vaccine, has been removed from the market. The ACT-HIB, Menhibrix, Hiberix, and Penticell vaccines require a total of 3 doses. The first dose is given at 2 months, but it can be given as early as 6 weeks, and the second and third doses are given at 4 and 6 months. The PEDVAX-HIB requires a total of 2 doses. They're given at 2 months and 4 months. The PEDVAX-HIB does not require a 6-month dose. All of the HIB vaccines can be used interchangeable if the brand of the original dose is unknown or unavailable. Regardless of which vaccine series the child receives, they also get a booster at 12 to 15 months. And any type of the vaccine that we just talked about can be used as a booster. The catch-up schedule for HIB is complex and depends on which series the child started, the current age, and the number of previous doses. And the algorithms for catching up are linked to on this slide here. One thing that's true for all children is that if they're unvaccinated or if their vaccine status is unknown and they're between 15 and 59 months of age, they should receive 1 dose of any type of HIB vaccine. All are given intramuscularly. Some come with a diluent and need to be reconstituted, so it's important to read the storage and handling instruction of whichever brand that you're using. Certain groups of children are at higher risk of HIB infection and have special recommendations. Some children are immunocompromised and at higher risk of infection, like those undergoing chemotherapy, those with asplenia, HIV, and immunoglobulin deficiency. Children aged 12 to 59 months who are at increased risk for Hib infection and have had 0 or 1 dose of vaccine prior to 12 months should receive 2 doses 8 weeks apart. Children aged 12 to 59 months who are at increased risk and have had 2 or more doses should get 1 more dose, if they're between 12 and 59 months. Those children under age 5 who are getting chemotherapy or radiation treatment who receive vaccine doses in the 14 days prior to treatment or during treatment need to have those doses re-administered 3 or more months after treatment completion. Anyone who has received a stem cell transplant needs to receive a 3-dose Hib vaccine series 6 to 12 months after successful transplantation. Those doses need to be 4 weeks apart. And any under-immunized children, 15 months or older, who are getting an elective splenectomy should receive a single dose of any Hib vaccine. Under-immunized is defined as any child who hasn't received a primary vaccine series and booster, or anyone who hasn't received at least 1 dose after age 14 months. Hib vaccines are not typically given to children over age 5, although under-immunized children age 5 and older who have anatomic or functional asplenia should get a single dose. Unvaccinated children and adolescents aged 5 to 18 who have HIV infection should also get 1 dose. The new figure 3 has visual guidance on vaccinating high-risk patients. Contraindications for use of the Hib vaccine are severe allergic reaction to a previous dose or age less than 6 weeks. Next, we're going to talk about the vaccine that protects against pneumococcal disease. So there are 2 pneumococcal vaccines that protect against pneumococcal disease. Pneumococcal disease is a bacterial infection caused by strep pneumonia. Pneumococci can cause many types of infection, and pneumococci are the most common cause of bacteremia, pneumonia, meningitis, and middle ear infection in young children. Pneumococci cause invasive disease when they travel to sites of the body that are normally sterile, like the blood, lungs, and brain, or cerebrospinal fluid. Invasive pneumococcal disease, which includes bacteremia, pneumonia, and meningitis, is a nationally notifiable disease. Children at high risk of infection include those under age 2, those in group care, sickle cell anemia, HIV, chronic heart and lung conditions, cochlear implants, and cerebrospinal fluid leaks. Pneumococci are typically found in the respiratory tract of children and adults, with an estimated 20 to 60% of school-age children being carriers. It's unclear why the pneumococci don't cause disease in all carriers, but this is the reservoir from which the bacteria can spread to others. It spreads via respiratory secretions, from coughing and sneezing, and from saliva. Rates of disease increase in the winter and early spring, along with most other types of respiratory infections. Symptoms can be very severe, but could also be more mild, like fever and chills and ear infection pain. The complications of invasive pneumococcal disease, though, can be severe or deadly. Of children under age 5 who contract pneumococcal bacteremia, 1% will die. Children under 5 who get meningitis, about 10% will die. Pneumococcal disease is treated with antibiotics, but there's been an increase in antibiotic resistance over the last couple decades. In about 30% of cases of pneumococcal disease, the bacteria is resistant to at least one type of antibiotic that was normally used in treatment. The treatment challenges of pneumococcal disease underscore how important prevention by vaccination is. So there are 2 types of pneumococcal vaccine. There's a 13-valent vaccine that protects against 13 strains. It's recommended that children receive a 4-dose series of this. They're usually given at 2, 4, 6, and 12 to 15 months. Then there's a 23-valent vaccine that's only given to children aged 2 and older that have certain underlying conditions that puts them at high risk for pneumococcal infection. The table at the bottom of this slide outlines exactly which underlying conditions require the 23-valent vaccine and whether 1 or 2 doses are needed. The catch-up schedule for the 13-valent vaccine is complex and needs to be individualized. It takes into account the age, previous vaccine history, and underlying medical conditions. And I would refer to the catch-up schedule algorithm created by the CDC if you ever have to try and figure to catch somebody up. The pneumococcal vaccine is the pneumococcal 13-valent vaccine is given intramuscularly, and the 23-valent vaccine is given intramuscularly or subcutaneously. All of them are refrigerated, and as usual, the only contraindication is severe allergic reaction to the vaccine itself or to a vaccine component. Now we're going to talk about the influenza vaccine, which as of now, I think we're still giving. We had 2 kids in my office with influenza this morning, so it's still around. The influenza vaccine protects against the influenza viruses that circulate during the season. These viruses cause respiratory infection that comes on suddenly and can be mild or severe and can even result in hospitalization or death. There are 3 types of influenza virus, A, B, and C. Influenza A and B viruses cause seasonal epidemics nearly every winter in the United States. Influenza A causes moderate to severe illness in all age groups and can also infect some animals like birds and pigs. Influenza B typically causes milder infections that primarily affect children and can only infect humans. Influenza C infections cause a mild respiratory illness and are not thought to cause epidemics. Every year, an estimated 5 to 20% of the United States population is infected with influenza. Illness occurs across all age groups, but young children have the highest rates of illness. The virus is contagious and spreads via respiratory droplets. And it's also possible to get infected from touching objects contaminated by the virus. The flu season can go from October to May, with peak activity usually occurring between December and February. Symptoms include fever, chills, sore throat, cough, stuffy nose, sometimes vomiting and diarrhea. Most people will recover in a few days to a couple weeks, but some will get more serious complications. Some populations are particularly vulnerable to influenza complications. Severe illness, hospitalizations, and death disproportionately affect patients who are very young or very old, those who are pregnant or have chronic medical conditions like asthma and neurologic disorders. Complications from influenza include pneumonia, worsening of chronic illness, and death. Asthma patients experience high rates of influenza-related hospitalization due to respiratory complications. Children with neurologic disorders also experience high rate of severe complications, and children aged 2 and younger have the highest rate of mortality. In the last flu season, there were about 30 hospitalizations per 100,000 people. The highest rates of hospitalization occurred in people over age 65, and the second highest were in children aged 0 to 4. Since 2004, the total number of influenza-associated pediatric deaths is usually anywhere from a few dozen to a few hundred a year. There were about 75 deaths last season. Influenza can be treated with antiviral drugs, but is usually treated with supportive care. The photo on the left here shows respiratory droplets being released when someone sneezes. The photo on the right shows an emergency hospital set up to deal with the huge number of people who were sick during the 1918 pandemic. New influenza vaccines are created each year in an effort to best protect against the viral strains predicted to be circulating for the upcoming flu season. In previous years, there were 2 main types of vaccine: an inactivated influenza vaccine and a live attenuated influenza vaccine. The inactivated vaccine was a shot, and the live vaccine was the nasal spray. IIV is the inactivated vaccine, which was previously called the trivalent vaccine. The IIV abbreviation is usually given a number that shows how many strains it protects against, 3 or 4. There are a few IIV options other than the standard vaccine. RIV is a recombinant influenza vaccine. This is made with recombinant DNA and has the trade name Flublok. CCIIV is the cell culture inactivated influenza vaccine called Flucelvax and is a quadrivalent vaccine. There's also high-dose trivalent inactivated influenza vaccine available called Fluzone High Dose. The new recommendation from the CDC's ACIP states that the live attenuated vaccine, the nasal spray, should not be used this past season, the 2016-17 season. The reason for this is due to newly available vaccine effectiveness study data from the CDC that showed that the nasal spray had poor or relatively lower effectiveness compared to the inactivated vaccine from the 2013 to 16 years. I'm not sure if it's going to, the nasal spray will be back next year. I know that in our office we just ordered it, so presumably the companies that make it are intending for it to be out there. Hopefully it'll be out there. There'll be a lot of not happy kids this year, but at least we have a vaccine that works. In this presentation, we're only going to talk about the ones available currently for the pediatric population. There are many trivalent and quadrivalent vaccines available at varying ages. It's important to choose one that's licensed for use in whatever age your patient is. Included here is a table listing the complete options for pediatric inactivated influenza vaccines for this season. The U.S. has a universal recommendation that anybody aged 6 months or older get vaccinated against influenza. There are very few contraindications for getting the flu vaccine. Children between age 6 months and 8 years may need 1 or 2 doses, depending on the algorithm diagrammed on this slide. If a child has received 2 or more total doses of trivalent or quadrivalent vaccine before July 1st, 2016, they get 1 dose this season. The 2 or more doses before July 1st, 2016 don't have to be from the same season or even from consecutive seasons. If a child has not received 2 or more doses prior to July 2016, or if their immunization history was unknown, they should have gotten 2 doses this past season that are at least 4 weeks apart. All of the inactivated vaccines are given intramuscularly and are refrigerated and are not given to anyone who has a severe allergic reaction to a previous dose or any component. It used to be that we weren't supposed to give flu vaccines to kids with egg allergies, although my understanding now is that it's okay to give as long as they're able to tolerate baked eggs, or if they don't have a severe anaphylactic reaction to eggs. And I've even heard from some allergists that it's okay to give to severe egg allergic kids, as long as they're watched in the waiting room for a half hour or so after they get their shots. Moderate to severe acute illness with or without fever is a precaution for the flu shot, and a history of developing Guillain-Barré syndrome within 6 weeks after a previous dose is also a precaution. Now we're going to discuss the HPV vaccine. HPV vaccines protect adolescents from certain strains of the human papillomavirus. There are over 40 strains of HPV that can infect humans, and some strains cause genital warts and cancer. Many HPV infections don't cause symptoms and are cleared by the body without people even realizing that they're infected. However, some strains persist in the body to cause more serious disease. As I said, it can cause genital warts, cervical cancer, and some less common forms of cancer like anal, penile, vulvar, vaginal, and oropharyngeal cancer. Both men and women are at risk for developing genital warts and cancer from HPV. HPV is incredibly common in the United States. An estimated 79 million people are infected with it. There are about estimated 14 million new infections every year. It's transmitted by sexual contact and is the most commonly sexually transmitted infection in the United States. Nearly all sexually active people will be infected with at least 1 strain of HPV in their life, and an estimated 360,000 people get genital warts from HPV every year. People infected with HPV are typically asymptomatic. Often they'll only know they have the infection by the appearance of genital warts or an abnormal pap smear result. HPV directly contributes to the burden of cancer in the U.S. Every year, approximately 18,000 women and 9,000 men are affected by cancers caused by HPV. It most commonly causes cervical cancer in women and oropharyngeal cancer in men. HPV is responsible for over 90% of cervical cancers. Cervical cancer used to be the leading cause of cancer death for women in the United States, but that's improved with the pap smear test, which catches disease earlier, but it's still a significant problem. Every year, as I said, there are thousands of women diagnosed with cervical cancer, and about 5,000 will die every year from cervical cancer. HPV is also responsible for 90% of anal cancers and over 70% of vaginal, vulvar, and oropharyngeal cancers, and 60% of penile cancers. There is no treatment for HPV infection itself, so its manifestations can be treated. The HPV vaccine is a very important tool in fighting cancer, so it's important that as healthcare providers, we make a strong recommendation for fully vaccinating adolescents when they come in. Women and men both benefit from being protected from genital warts and multiple forms of cancer, though some groups are particularly vulnerable and benefit more so from vaccination. We know that cervical cancer disproportionately affects women of lower socioeconomic levels who don't have full access to healthcare, those who are uninsured, and those who are recent immigrants. There are 2 vaccines available to protect against HPV. There's one called Gardasil, which there used to be a 4-valent. Now there's a Gardasil 9, protects against 9 strains of HPV. And that protects against 4 strains that were in the original Gardasil and 5 additional strains that are associated with about 14% of HPV-related cancers in women and 4% of HPV-related cancers in men. Both Gardasil and Gardasil 9 have been approved for use in boys and girls. The second vaccine is one called Cervarix, which has been removed from the schedule. So there are some places that are still giving just the 4-valent Gardasil vaccine, and that one protects against 2 of strains of HPV that are known to cause 70% of cervical cancers, as well as 2 other strains known to cause 90% of genital warts. One change this year is that the HPV vaccine is given as a 2-dose series rather than a 3-dose series if patients are younger when they get it. The series is recommended for boys and girls age 11 to 12, although this year the ACIP also allows vaccination starting at age 9 years old in non-high-risk groups depending on the clinical decision-making. The second dose is given 6 to 12 months after the first dose. If the vaccine isn't completed at 11 to 12, adolescents should start the series as soon as possible. If the series is initiated by age 15, the recommended schedule is the 2 doses separated by 6 to 12 months. If it's initiated at age 15 to 26, the recommended schedule is 3 doses, with 1 to 2 months between doses 1 and 2 and 6 months between dose 2 and 3. A vaccine dose administered at a shorter interval should be re-administered at the recommended interval following the guidance in the immunization schedule footnote. It's important to vaccinate adolescents as early as possible in order to give them the best protection against HPV. As they get older, it's more likely they will be exposed or infected with HPV. The vaccine is also recommended for women up to age 26 and men up to age 21, although men age 22 to 26 can also be vaccinated. We're going to discuss recommendations for special populations on the next slide. This goes over whether they should get 2 or 3 doses. For children with a history of sexual abuse or assault, the ACIP recommends routine HPV vaccine given at age 9. For men who have sex with men, ACIP recommends vaccine through age 26. For transgender persons, the ACIP recommends routine HPV vaccine, like for all adolescents, and vaccine up to age 26 for those who are not adequately vaccinated previously. Please note that the HPV vaccine is not recommended during pregnancy, although there's no evidence that it poses any harm. If a woman is found to be pregnant after initiating the vaccine series, no intervention is needed. The remaining vaccine doses are just delayed until after pregnancy, and pregnancy testing is not needed before HPV vaccine. These vaccines are given intramuscularly and refrigerated and protected from light. Finally, we're going to talk about vaccine against meningococcal disease, vaccines against meningococcal disease. So these vaccines protect against bacterial infection caused by Neisseria meningitidis. There are 5 different strains of this bacteria, A, B, C, W, and Y. The B, C, and Y strains cause most of the infections in the United States. Cases of meningococcal disease have been declining since the 1990s. There were about 550 cases in the last couple of years. The highest rates of disease occur in children under age 1 and in adolescents aged 16 to 23. Meningococcal disease follows a seasonal pattern with cases peaking in January and February. It's spread from person to person through respiratory droplets. About 10% of people are carriers of this bacteria, meaning they have it in their upper respiratory tract but don't have any symptoms of it. But they have a reservoir to spread it to other people. Meningococcal disease is very serious and can be fatal in a matter of hours. It most commonly manifests as meningitis or septicemia. It's important to recognize the symptoms. Meningitis symptoms typically appear 3 to 7 days after infection and begin with sudden onset of fever, headache, and stiff neck. Also nausea, vomiting, light sensitivity, and confusion. Meningococcal meningitis can lead to hearing loss, nervous system damage, brain damage, death. But in infants, the symptoms can look different. Infected infants may have irritability, vomiting, decreased feeding. The symptoms for meningococcal septicemia include fatigue, vomiting, cold hands and feet, severe aches and pains, dark purple blotchy rash that you really can't mistake for anything else. Treatment with antibiotics should be started as soon as possible if you suspect disease, and it must be reported to the Illinois Department of Public Health immediately. There are several available meningococcal vaccines that cover all 5 strains of the bacteria, but we're only going to talk about the pediatric ones today. There are 2 quadrivalent vaccines that protect against A, C, W, and Y strains. These are Menactra and Menveo, and they're part of the routine recommendations. Menhibrix is a combination vaccine that protects against the C and Y strains, as well as Haemophilus influenza type B. And it's only used in high-risk populations we're going to talk about in a second. The routine pediatric vaccine recommendation is to give 1 dose of Menactra or Menveo to children aged 11 to 12 and then a booster dose at age 16. It's also recommended that any 11 to 18-year-old with HIV should get 2 doses separated by at least 8 weeks. And it's recommended that children aged 2 months to 18 years who are at higher risk of contracting meningococcal disease follow an altered vaccine schedule. The risk groups for this recommendation are children with anatomic or functional asplenia, persistent complement component deficiency, those traveling to areas where disease is endemic, and those who may have been exposed during an outbreak. The schedule is complex and depends on which risk group they're in, their age, and their current vaccine status. And there's a table immunization.org that gives the recommendations for that. There are new recommendations this year regarding children who have HIV getting the meningococcal vaccine. If a child is under age 2, they should get either 4 doses of Menveo or 2 doses of Menactra. If a child is 2 or older, they should get either 2 doses of Menveo or Menactra 8 to 12 weeks apart. Booster dosing depends on the age the child was at when they received their initial vaccine series. If a child is younger than age 7, they should receive a dose of Menveo or Menactra 3 years after the primary series and additional boosters every 5 years thereafter. If the child was 7 or older, they should receive a dose of Menveo or Menactra 5 years after the primary series and additional boosters every 5 years. There's a table on the CDC that gives more detail about this. If a child does not receive Menactra or Menveo at 11 or 12, they should follow a catch-up schedule. If they get 1 dose between age 13 to 15, they should also get a booster dose at age 16 with a minimum of 8 weeks between the 2 doses. If 1 catch-up dose is given at 16 to 18, then no booster dose is required. There are also 2 FDA-approved vaccines for the B strain of meningococcus called Bexsero and Trumemba. These vaccine doses are not interchangeable, so you have to stick to 1 brand or the other to finish the series. It is recommended that any people age 10 or older get the series if they're at high risk of infection with the B strain. The risk groups for this recommendation are children with asplenia, complement deficiency, or those who have been exposed during an outbreak or are traveling or residing in areas where meningococcal disease is hyperendemic or epidemic. Bexsero is a 2-dose series and Trumemba is a 3-dose series. Adolescents aged 16 to 23 can also be given the B strain series, preferably between age 16 and 18. The ACIP considers this a Category B recommendation, which means that the administration of the vaccine for this group is at the discretion of an individual clinician. A new recommendation from the ACIP this year is that adolescents in this category can be given a 2-dose series of Trumemba instead of 3, as long as there's 6 months between dose 1 and 2. Menactra is refrigerated. Menveo is supplied as 2 doses, 2 components, that need to be refrigerated. And there are some details here on how to store the vaccine. All of these meningococcal vaccines are given intramuscularly. And that covers the vaccines for which there are new recommendations in the 2017 schedule. And it looks like we have a few minutes for questions if there are any.
Thank you, Dr. Goldstein. We'll just give it a couple minutes to see if there's any questions from the attendees, and I'll let you know what their questions are.
Sounds good.
Okay, I got one question. If someone has had tetanus as a child, are they still at risk for the disease?
I believe the answer is yes, because there are different strains of the bacteria that can cause disease. So the recommendation would still be to get vaccinated. I know the only vaccines I know of that you don't need to get vaccinated against if you have proof of immunity is chickenpox and the MMR vaccine. But I believe for tetanus, even if you had it, you're supposed to get You're supposed to get booster doses.
Thank you. And I've got a couple questions asking if we're going to be sending out the slides after the presentation, and yes, we are. Okay. I think that's it. So I want to thank everyone for joining today's webinar. This week you'll all receive an email with a link to the recording of today's webinar, a PDF of the PowerPoint slides, and a link to the evaluation. You'll have 2 weeks to complete the evaluation by April 18th. After 2 weeks, the evaluation will be closed, and you'll no longer be allowed to fill out the evaluation, receive a certificate of attendance, or continuing education credit. So we strongly advise that once you receive that link to the evaluation, fill that out as soon as possible. And we'd like to thank you, Dr. Goldstein, once again for an excellent presentation, and to everyone for joining today's webinar. We hope that many of you will join us for some of our future webinars, and have a great day.
Thank you.
Thank you.